So my name's Tricia Santos. I am an endocrinologist. I work here in San Diego at the University of California with Steve and Jeremy, who you've heard a lot from already today. And this talk is to kind of look at some other therapies that can be used along with insulin, but that aren't insulin. So we're not talking about all different types of insulin or inhaled insulin or any of those therapies. These are really non-insulin therapies. So I won't be offended if you want to leave and this talk wasn't what you thought it was, and you can go to another one. So there's I'll start by saying there's lots of other treatments out there that are potential options for type 1s. I'm going to focus on the two that are being most well studied right now, but we'll have plenty of time at the end if you have other questions about these medications or if you have questions about other medications that we didn't talk about today. So I just want to start off by comparing the classes of diabetes medications we have for type 2 diabetes versus what's available for type 1. And it's kind of interesting because if you look at type 2, this list that I have up there isn't even all the drugs that type 2s have available. These are the classes of drugs, okay? So within each of these classes, there's, 2, 3, 4, 5 different types of drugs. So imagine how many drugs are out there and available for people with type 2 diabetes. And as you know, for type 1 diabetes, we have insulin. And you've heard already today about how insulin is really a remarkable life-saving therapy. So I definitely don't want to knock insulin. But since insulin was discovered in the 1920s, we've had nothing. Until 2005, when Similant came out. Anybody here on Similant or been on Similant in the past? Okay, so quite a few of you. So I'm actually not going to talk about Similant today in detail, only because a lot of people have tried it or know about it, and not that many people are using it anymore. But I'm happy to talk about it at the end if those of you, for people that have questions. And the quick thing I'll say is that Similant works. Okay, it works very well. There's some limitations to its use, mostly that it can cause some nausea and that it's an extra injection every time you eat. And those are kind of the two main reasons that people who may have started it don't take it anymore, but it does work. It is approved for type 1 diabetes. It's the only other medication besides insulin that's FDA approved. So if you're looking for something out there and you can't get any of these other things covered, this is a good option. All right, the last thing I'll say about the type 1 medications is they're all injectable. And it sure would be nice to have something that maybe was a pill that you could take like all these type 2 medications. So what if there was something new I could take with my insulin? Well, is that a good thing or a bad thing? Do we really need something else besides insulin? And I think there's arguments for both sides. We could really probably do a debate up here about it if we wanted. So in my experience, what I'll say is I treat a lot of patients with type 1. I do use these medicines that we're going to talk about today. We use them off-label because they're not FDA approved right now, but we can get them for many of our patients. And I think the biggest benefit to using an additional medicine in addition to insulin is improving time and range. And people mentioned this a little bit this morning, but time and range is very different than A1C, because with A1C, as you know, you can have an A1C of 7, but your numbers can be all over the place, because the A1C is just taking the average of those high highs and the low lows and telling you what your average has been for 3 months. The time and range really says what part of the day are you actually within that kind of blood glucose range that you should be in, which to me is much more important because you're talking about getting rid of those real high numbers and those real low numbers. Does that make sense? And I think that's probably the biggest benefit to these medications. It can also sometimes make small changes to improve the A1C. The medications I'm going to talk about today cause weight loss. And for most people, that's a good thing. For some people, they say, no thanks, I don't need to lose any weight. They can allow you to use less insulin. For some people, that's a really great thing. For others, they don't care about how much insulin they're using, just as long as it's working. So again, this is really kind of a personal decision, and it can possibly reduce the amount of low blood sugars. What about the downsides to using these? Well, you still need insulin. So I can't hammer that point home enough that these therapies are not replacements for insulin. So it's really something else additional to the insulin. And some people are saying, gosh, it's just one more thing to think about. No thanks. I've got my finger sticks to do. I've got to look at my CGM. I've got to give my injections or worry about my pump. And it's just too much to add another medication. And I don't like taking medication, so why would I add another one? Insulin is the thing that's deficient. Let me just replace the insulin and kind of be on my way. And that's true, and that's fine, okay? Also, every medication comes with potential side effects. So insulin potential side effects most commonly are hypoglycemia and weight gain. These medicines that we're going to talk about today also have side effects. And like I said, they're not FDA approved for type 1, and I'll say yet, because I think they will be soon. So the two classes of meds that we're going to talk about today are called GLP-1 receptor agonists and SGLT2 inhibitors. And I have to say, I don't know why they make these drug classes so darn difficult to say. Even for the doctors, so I teach the internal medicine doctors at the university, and they cannot remember these classes. I mean, it's a mouthful to try and say these different names of these drugs. So I don't blame you if you kind of get a little confused with all these letters up here, but I'll try and keep it straight. Okay, so the first class we're going to talk about is GLP-1 medications, okay? GLP-1 is actually a hormone that we all make. All of us make this hormone, and it comes from our gut. It's a gut hormone, okay? So what happens is when you eat and the food gets to the end of your small intestine, your gut makes this hormone called GLP-1 and puts it into the bloodstream. So what does that hormone do? Well, this hormone makes your beta cells secrete more insulin. Okay, well, everybody says, well, thanks, that's not very helpful because my beta cells aren't working or aren't there and can't make insulin anyway. So bear with me. So that effect obviously doesn't help us with type 1, okay? But GLP-1 does other things. So did anybody know that your glucagon levels in type 1 actually go up after a meal? That makes no sense, right? Think about it. We give glucagon as a treatment for low blood sugars. Glucagon makes the blood sugar rise. Why would we want it to go up after a meal? So this is something that is abnormal in patients with both type 1 and type 2, actually, where the glucagon rises after a meal. So if we can make that go down a little bit, that's a good thing. So this can actually help people with type 1 diabetes because it can make that glucagon after a meal kind of calm down a little bit. Okay? That actually helps your liver from making too much sugar, which is another problem we have in diabetes, where the liver just kind of goes crazy, okay, making too much sugar all the time. And then in your brain, these medicines make your brain think that you're full faster, okay? And they actually leave the food in your stomach a little longer. So the food empties out of your stomach a little bit more slowly than usual, okay? So these are how this is how that normal hormone, remember, everybody makes this hormone. This is how that hormone works. And these medications, the GLP-1 medications, work just like this hormone. So it's like you're giving your body extra hormone. Does that make sense? Okay. All right, so there's several of these medications that have actually been approved already for patients with type 2 diabetes. They're all injectable. Okay? So these medicines are either given by a daily injection, which can be once or twice daily for these short-acting ones listed here, or by a weekly injection for these longer-acting ones. So these are given just once a week injection. Okay, so pretty easy to take for the most part. Now, you say these were made for type 2s. Well, they actually work for me. I have type 1. You know, I'm telling you about these type 2 medications. So it turns out they actually do work in type 1, and there have been lots of studies that have looked at this. So I'm just going to show you a couple of studies to prove to you kind of what these medicines are doing for people with type 1. So this particular study looked at, this is in patients with type 1 diabetes with one of these GLP-1 medications called Victoza. Anybody here ever tried Victoza? Okay, so we have a few. I'd like to hear from you after. Maybe you can tell us how you like it or what your experience was. And what you can see is it didn't change the A1C all that much, right? Yes, the A1C went down, but by about 0.3%. That's not too much, right? But for this small drop in A1C, the average basal insulin dose went down by 13 units, okay? This was about a 50% reduction, okay, in the insulin dose. The bolus insulin dose went down 11.5 units. Again, these are averages. Some of you may say, I'm not even on 13 units of basal insulin. Does that mean I can come off of my insulin? No, you would have less of a reduction, okay? But these were in patients who were on higher doses. And look at the weight, okay? This is about a 10-pound weight loss. So again, it shows that this medication really does do something in patients with type 1. And then I'd like to show you this kind of, we call this a spaghetti plot. It looks like kind of a bunch of pieces of spaghetti, you know, laying down on a graph here. And it looks a little bit messy. And this is how the blood sugars look in type 1, right? They're kind of all over the place. Different things happen on different days. And what you can see here is these are CGM tracings. Each color is a different day. And you see a lot of variety, okay? And this green bar here is representing blood sugars of 80 to 130. That's a pretty tight control. That'd be an ideal blood sugar for the morning when you're fasting, okay? And after taking Victoza for 6 months, you can see it improves that time in range. So those high highs go away and those low lows went away, okay? This is one study. The only reason I put this in here, and this is kind of a busy slide, but this was just published about a week ago here in San Diego at the American Diabetes Association big scientific meeting. And it was a new study in overweight patients with type 1 who were on pumps, who took Victoza. Again, you saw in the people who took Victoza, which is liraglutide here, who were also using their pump, they had an A1C drop of 0.6%. The people that just stayed on the pump alone had an A1C drop of 0.2%. But the big differences you see are the weight loss with the Victoza and more time in range. So again, that time in range concept is becoming really important. So you say, gosh, that sounds darn good, these medications, right? Do they have any other benefits? And the one thing I do want to tell you about is a big, big study that was done in patients with type 2 diabetes who are at high risk of heart disease. And this was kind of landmark results. This medication was shown to decrease the risk of heart disease in patients who already had it, who are already at high risk, okay? And that's independent of what it did to their blood sugars. It had nothing to do with their blood sugars. It independently decreased their risk of heart disease. So it has, what the thought is that it has some other effect in our body that we don't know about yet that's protecting the heart. Okay, so that's also good news.
What was measured to prove that?
So the primary endpoint, the question was what was measured to prove that, and the primary endpoint in that study was a composite endpoint called MACE. So these are major adverse cardiac events. So they measured death from cardiovascular causes, stroke, and heart attack was the main things that they looked at. Yes, so this study with the heart disease was in people who are at high risk for heart disease. So they already had it, or they had multiple risk factors that put them at high risk. So we don't know yet if that helps people that don't have heart disease, because they haven't done those studies yet. But it's certainly interesting. So you say, okay, that sounds great and all, but I'm kind of scared to try something new. And what do I have to worry about with these medications? So the side effects. You may predict that the most common side effect with this is nausea. And you can think about that, right? Because remember I told you this hormone makes the food kind of sit in your stomach for a long time, and the stomach kind of slowly empties out over time. So these medications can cause nausea. Now I do have to say, the nausea usually goes away over time. Are people that have tried it before, did you guys experience nausea, and did it stay? 5 to 6 days.
Yeah, I titrated down for about 6 weeks.
Okay, perfect. So you said you titrated down for 6 weeks. So these medications, most of them, not all of them, can be given in multiple doses. So we start very, very low dose, And the manufacturers in some cases will say you can increase every week. I find that in type 1s that's too fast, and you usually have to increase a lot slower than that. And so some patients, if you go up to a higher dose and you feel nauseous, you can just go back down like you did until your body kind of gets used to it, and then you can kind of slowly go back up again. So what I would say is go to a dose that your body can handle, that you can tolerate the nausea. Nobody's going to take a medication that's making them feel sick all the time. But this is by far and away the biggest side effect. There was also, in the animal studies, they saw an increased risk of a very, very rare type of thyroid cancer. And that's because these rodent animals have more of this particular type of thyroid cell than humans do. So this hasn't really been an issue in humans. It hasn't come up as an increased risk in human studies. And the only reason I'm really putting it out there is in case you hear about it. I just want you to know that this has been something that's seen in animals and not humans. Okay? And then there's also been some talk of, do these medications cause pancreas problems, like inflammation of the pancreas? And the FDA actually did this huge review, looked at all of the studies that were done in animals and humans, and they could not prove that these medications cause pancreas disease. So that's also kind of one of those rumors that's out there that we don't think is true. Okay, so that's wrapping up on the GLP-1 medications. Okay, remember that was that hormone that's made by your gut, okay, those injectable medications. Now we're going to move on and talk about the second set of medications, and these are actually pills. And I think this is a really cool concept because this is the first oral pill form of a medication that's been used and studied in patients with type 1. I think people are sick of feeling like a pincushion all the time. And to be honest, most of my patients aren't that bothered by the injection side of things. But for those that are, this is another option. So these pills are, again, another medication that has been already approved for patients with type 2 diabetes. Okay, these are the brand names here called Invokana, Farxiga, and Jardiance. Okay, so these are remember I told you it's kind of a mouthful, the SGLT2 inhibitors. And these work on your kidneys. Okay, and this is a little bit complex, but I'm just going to show you what it does. So first, I'm going to show you what happens under normal circumstances in all of us and how our kidneys handle blood sugar, okay? So this little purple hexagon here is glucose. And glucose, all your glucose in your blood gets filtered into your kidney. It all goes into your kidney. And then your kidney actually puts all the glucose back into your bloodstream because the idea is that your body wants to use that sugar for energy, right? So your kidney does that by putting the glucose through this little tunnel called SGLT2. That's the way you can think of it. It's basically just this little tube that the glucose travels through to get back into the bloodstream. So under normal circumstances, none of this glucose in the kidney gets into the urine. It all goes back through that little tunnel into the bloodstream. Does that make sense? Now, these medications are called SGLT2 inhibitors. So if you block this tunnel, okay, where the glucose used to go back into the bloodstream, the glucose can't get in there anymore, right? It can't get back into the blood. So what you start doing is dumping glucose into the urine. And that's a really hard concept to think about because for all your life, you've been told that it's bad if you have sugar in your urine. Right? So it's a hard thing to kind of wrap your head around, like, wait a minute, now you want me to put all my sugar into my urine? But basically, the short term is, if these figures were kind of too complex to understand, the short way to think about these is they make you pee out your sugar, okay? And they don't rely on your pancreas to work. So that's why these pills can be used in patients with type 1. This is similar to that other graph I showed you. So this is looking at these medications in a study that was done in patients with type 1 diabetes. So this is one patient's CGM tracings. Remember, each one of these lines is a day. And this looks pretty classic, right? You have good days and bad days. Some days you have a lot of highs. Some days there's a lot of lows. kind of all over the place, okay? And after using this SGLT2 medication, you can see the time in range that we talked about, the time that your blood sugar is in that target range is much better. Is it perfect? No. But you can see the difference in these two graphs, right? Okay. So this medication I want to bring to your attention in particular, and this is one of the SGLT2 inhibitors, those medications that make you pee out your sugar, called sotagliflozin. I told you these are kind of a mouthful to say, okay? Yeah, bless you, yeah. So this medication is kind of cool because this one in particular is being studied for people with type 1. This medicine is not approved for patients with type 2, and they're really looking to get it approved first in people with type 1, which is kind of cool. So this actually blocks SGLT1 and SGLT2. SGLT1 blocks glucose absorption from your gut. So it has, you absorb a little bit less glucose from your meals. That's how that works, okay? And then the SGLT2, I told you, makes you pee out your sugar. And when you take these medications, if you guys have all seen those sugar cubes before, right, for coffee? Okay, so this is about how much glucose you put in your urine every day when you're taking one of these medicines. Okay, pretty impressive, I think, and really shows you how much these can work. So this medicine, like I said, is being studied for type 1, and I'm just gonna show you the results of one of the studies when patients took it for 28 days. So they showed a decrease in the dose of the insulin these patients needed, similar to those other studies we looked at, a lower A1C, lower blood sugars after meals, so reduce that spike after meals. There was no increase in hypoglycemia. It reduced the variability, that's that time in range that we keep talking about. It caused weight loss. So if you think about it, when you're peeing out glucose, you're peeing out calories, right? So similar, many people maybe when you were diagnosed, you were peeing out a lot of your glucose, and so that's why you had weight loss at diagnosis too. So this is similar, it causes a little bit of weight loss. And it's been determined to be safe, and they're moving on to do other studies with this medicine and hopefully get it approved in type 1. Yes?
If you have kidney disease, does it make the kidneys work harder?
Yeah, so the question is, if you have kidney disease, does it make you work harder? So there's a couple of things about kidney disease and these medicines. A lot of people have already asked me today if they are damaging to your kidneys. So there's two things. Number one, if you have kidney problems already, these medicines can't be used, and that's only because they just don't work that well. Because your kidneys have to be filtering a lot of glucose through them in order to put that in your urine. So if your kidneys are a little bit on the sluggish side, a little slow, they're not going to work that well. Okay? Now the second issue is, are they safe for your kidneys? Whoops. Uh-oh. Are they safe for your kidneys in the long term? And obviously these medicines have not been around for, 20 years, so we don't have that kind of data. But what I can tell you, and it might be on my next slide here, is there was a very big study done in type 2 diabetics, and this was similar to that Victoza study that we looked at, where they looked at people who had increased risk of cardiovascular disease, and they actually showed that this medicine decreased the risk of cardiovascular disease, that means heart disease, okay? And it decreased the risk of progression of diabetic kidney disease. So it seemed to be protective for people who had diabetic kidney disease. Okay, so right now the data that we're showing is not only is it not dangerous, but it may actually protect your kidneys. Yes?
Do the SGLT2s increase UTI?
That was really impressive that you were just able to say SGLT2 so quickly. Oh, okay. Okay. So the question is, do the SGLT2s increase your risk of UTIs? And that brings me to my next slide, and the answer is yes. So it turns out that when you put a bunch of sugar in the genital urinary system, that bacteria and yeast, that's what they eat, okay, particularly yeast actually. So the UTI risk does go up, but it's more yeast infections, and the yeast infections are higher in women and in uncircumcised men. It doesn't mean that if you get a yeast infection while you're on these medicines, it doesn't mean you have to stop them. You can treat the yeast infection and keep taking it. If you're getting a lot, it's probably not a good idea, right? But that is one of the side effects of these medicines. They also cause weight loss, which we talked about, and they lower blood pressure. Now, the lower blood pressure is a good thing for many people. It can be a bad thing if your blood pressure is already on the low side. Okay, yes?
Would an increase in water intake help decrease the yeast infection or not?
So the question is, would the increase in water intake decrease the risk of yeast infections? And it doesn't really, because that sugar is still there. It's a good thought, but it does. That sugar is still there. Now, yeah, these medicines, because whenever you're peeing out a lot of sugar, it actually takes water with it, and that makes you thirsty. So increasing the fluid intake is not a bad thing with these medicines. It can make sure that you don't get dehydrated. Yeah. Yes?
How does it block going into that little, on your one slide?
That tunnel?
Yeah, how does it block that?
So the question is, how does it block that tunnel? And basically, the shape of the medicine, the shape of the way the medicine is made, fits right into that tunnel and just stops it. It's just like a puzzle piece. It fits right in there and literally blocks it. It physically blocks it, so nothing can get through.
This is an operation or what?
Oh, no, sorry. So this is a pill, and it's not an operation. It's a pill that literally goes into your body, goes to your kidneys, and blocks that area.
And how often do you take the pill?
The pill is once a day. Once a day.
So it dissolves eventually.
Yes. Yes. Yes, in the back.
You said that you have kidney disease, you can't take that, but then you said if you take it, it may help prevent or. that's
Yeah.
what you're getting close to.
Yeah, so you're right. That was a confusing statement. So the question is, if you have kidney disease, you can't take it, but it also helps you if you have kidney disease. So that seems a little conflicting. So basically, if you have mild kidney disease, you can take these medications. If you have significant, moderate to severe kidney disease, then you can't take them. So it all depends on your level. In patients who do have kidney disease, mild kidney disease who take them, it does seem to be protective and help. There's another question here.
Have there been any studies on the effect of taking the GLP-1s and the SGLT2s
Together. I'm not aware of any studies where they have combined the SGLT2s and the GLP-1s in type 1s. In type 2 diabetes, certainly we do use these medications together, and they actually work very well together. And there are type 1s. I don't have any personal patients, but I have met type 1s who are on both. Now, the thing you have to be careful of that I do want to mention very quickly, and then I'll answer some more questions, is has everybody heard of diabetic ketoacidosis? Are you familiar with this term? You may have heard about it when you got diagnosed, for those of you that were in DKA. And this really happens when your body doesn't have enough insulin. There can be a lot of reasons for this. Either you weren't diagnosed yet, or you're not taking your insulin, or you had some other stressful infection or surgery, or something else happened to your body. And this is where you kind of feel like you have the flu. You may feel very tired and weak and nauseous. And you check your blood sugar, and it's usually very, very high. 400, 500, 600 in people who have DKA. Well, if you get DKA and you're taking an SGLT2 inhibitor, your blood sugar can be relatively normal. And I don't mean, like 90 or perfect, 120, 130, but maybe it's only 180, 190, 200. So not really, really high, but you still could be in DKA. And the reason we think this happens is partly because you're able to lower in some people, they're able to get down on such low insulin doses with these medicines. And that kind of contributes to this problem. So there is an increased risk of DKA with relatively normal blood sugars. We call that euglycemic DKA in type 1s who take this medication. Okay? And that's why it's very important that if you're on these medicines and you have any symptoms that could be DKA, like nauseous, feeling really tired, all those feelings like you have the flu, you need to have a ketone meter and be able to check for ketones, okay? So that's an important thing to think about. And lastly, I just want to wrap up by saying, first of all, I want to remind you that these medications are not replacements for insulin, okay? Your body still needs insulin as a medication. They're additions. And you don't have to have another medication in addition to insulin to have good control of your diabetes. It's absolutely not necessary. I have plenty of patients that say, no way, I do not want another medication, just give me my insulin. That's all I'm missing, and so that's all I want to replace. And I have a lot of other patients that say, please, I've been on insulin forever, can you just give me something else, Or I have patients that just want to lose a little weight and get down on their insulin doses. So these are all very personal decisions. And, this talk is really to just kind of give you information and some education about what's out there so you can discuss with your doctor more. And I'm happy to leave the rest of the time so we have plenty of time for other questions. Yes? Yes, so what's the difference between Invokana, Farxiga, and Jardiance? So those are the 3 SGLT2 inhibitors. Those are the ones that make you pee out your sugar. Those are the 3 that are FDA approved right now for type 2 diabetes. There's not a big difference in between the 3 of them. The Invokana and the Jardiance so far have published big studies that show that they're protective for the heart, okay? In terms of reducing heart disease, like I mentioned. So that may be one difference. In terms of how well they work on lowering the blood sugars, they're all very similar. And so usually when I'm deciding in a type 2 in particular who take these medications frequently, it's whatever one's covered by their insurance is the one that I use. Uh-huh. Yeah.
I just didn't want to throw another.
Yeah.
So it's good to hear that they are more protective rather than harmful.
Yeah. I mean, right now we don't, like I said, we don't have long-term data on what these medications are doing, but right now all the data is showing that they may be protective for the kidneys and that they are not damaging the kidneys. That's right. Yeah. How did you, if you want to just tell the group, how were your blood sugars when you were on it? Did you notice a difference, or did you come down on your insulin doses?
No, I didn't change a lot of my insulin dosages, but I'm on Novolog and just on old school still.
Mm-hmm.
I don't have any of the pumps or CGM or anything, so I didn't notice a lot of difference, but I took 1 pill a day, and then it seemed intuitively like I liked it. I don't know. But I want to go back on it, I think. And
Okay.
try it again.
Do you feel like it helped your time in range?
Yeah, it
Yeah.
did. It did. It kept it a little bit more steady.
Okay.
Not a lot of,
Not as many highs and lows. So she's saying she took Invokana, which is one of those that make you pee out your sugar, and she felt like she had less highs and lows, so more time in range. Yes?
So generally, when you said they take less basal, less bolus injections, do you know what sort of time frame you're looking at for decreasing their rates?
Yeah, so
Days or what?
right, so that's a good question. So the question was, what time frame do you kind of reduce your insulin over? So the SGLT2 inhibitors, the ones that make you pee out your sugar, they work pretty quickly. So when we put people on these medications, we tell them to decrease their insulin up front. We don't wait, because it could increase their risk of lows. So we always say up front, and how much you reduce it kind of depends on what your blood sugars are running. If your blood sugars are already really, really tightly controlled, I'm going to reduce it a lot, because I don't want you to get low. Whereas if you're pretty high most of the time, then we worry less about that. But we definitely reduce it up front. With the GLP-1 injectable medicines, we also usually reduce up front, but because those can kind of be gradually increased, sometimes you have to do it gradually as well. So you reduce a little bit and then more and more as you go higher on the medication. Yes, in the back.
What is the time frame for FDA approval of sodium?
That I don't know. I would guess it would they're still doing studies. They haven't filed an FDA with the FDA right now, so I would guess it's going to be a couple of years. Yes.
Where does Similant fit on? Because I've been on Similant.
Yeah, so, I mentioned in the beginning that Semillon is the only other FDA-approved medication for type 1 diabetes, and because it's a little bit older and people have either been on it or aren't using it anymore, I didn't go into detail about it. But Semillon is, it turns out that your body actually secretes another hormone with insulin from the beta cell called amylin. So Semillon is just a synthetic form of amylin, which means it's amylin that's been made in a laboratory to be a medication, okay? And Semillon works very similar to the GLP-1 medications, actually. It helps slow down the stomach from emptying the food quickly, makes you feel full faster, it decreases that glucagon that we talked about. And Semillon is an injection that has to be taken at the beginning of every meal. And people that are on Semillon, you can tell us your experience, but my patients will tell me, and I see it very clearly, it works. So what it does is it prevents that spike after a meal. You'll see, if the spike's way up here, usually you see a much smaller spike after a meal. As we kind of talked about, the main reason people don't take it or stop taking it is because of the nausea, and because it's an injection before every meal. Tell us about your experience on Similant.
I am the poster child.
Uh-huh.
For the company, I guess it's not even anymore. When I started insulin, I gained 90 pounds in the first year. I started Similant, and I lost 80 pounds in 4 months. I went off because I was developing a skin reaction at the time. It was syringe and vial, and I'm allergic to apparently I'm allergic to whatever they used in the vial. Came out with the insulin pen, obviously Similant pen, and I'd gone up, I'd gone back up, and I went back down to like 10 pounds, like from where I had originally dropped. So it's been a lifesaver for me. I mean, to have all that extra weight to carry around was a lot of weight. And, I looked at these other drugs that they tell me I have to go off my Similant, and I'm scared to do that.
Yeah, no, and Semillon works. I mean, it really does a nice job, and it works so well, in fact, that with patients on Semillon, you definitely have to, we decrease the dose of insulin with meals. Yeah, yes. So we usually decrease it, in half to start. Some people need a little more or less, but it's the mealtime insulin that's really affected. So you stay on the same basal dose usually, and then you would decrease your mealtime insulin if you started Semillon. Yes?
How does Similant fit in with the slow and fast acting? Where is that? Is it fast acting or slow acting?
So the question is, how does Semillon fit in with the fast and slow acting insulin, you're asking? So Semillon is not insulin, technically. It's another hormone. It's mimicking another hormone that comes from the beta cell that is not insulin, but it works on the mealtime blood sugars. So you take it right before meals, similar to kind of a fast-acting insulin. Okay. Not instead of. So you still take a mealtime insulin, but you usually just need less. Yeah. In the back? Yeah. Yes, so the question was, any thoughts on type 1 and metformin? Is anybody here on metformin? Okay, so good, there's a handful. So I do use metformin in type 1 on occasion. There's a few different reasons to use metformin. So how many people have heard of metformin? Oh, good, wow, okay. So metformin is the first medication that we start in every patient with type 2 diabetes. Okay, it works by telling the liver not to make too much sugar overnight. And it works mostly in people who have a little bit of insulin resistance, we call it. So these are people who may be on higher doses of insulin, and there's a lot of different reasons for this, but because most patients with type 1 don't need a ton of insulin. But if you notice you need very high doses of insulin, then sometimes metformin can help. And I've had variable results when I use it in type 1. I have some patients where it works really, really well, and some where it doesn't do much. But usually when it works well, it's in those patients that are requiring high doses of insulin. Yes?
So if somebody isn't overweight and doesn't have constant exposures too high and too low, is the only reason to take those because it might protect your kidneys?
So the question is, if someone's not overweight, so they don't need to lose weight, and they don't have too much variability in their blood sugars, do you really need to take one of these other medications unless you want to protect your kidneys or get another benefit? And the answer is really, it's a personal answer. And it kind of goes back to, do you feel like you really want one of these other potential benefits, reducing heart disease, protecting the kidneys? Again, those were type 2 studies, but they're still out there. Or do you just feel like you would like to be on less insulin and have another medication kind of in your pocket to be using with these for your diabetes? It's really a personal question. And people just some people don't feel that strongly about it, and they say, I'm doing fine on my insulin. Why should I rock the boat? And some people just really feel like they want some extra help, or they want to be able to add something else besides insulin.
You as a doctor, what do you recommend for someone like that?
So the question is, what would I recommend to my patients? And if I had a patient who was not overweight, who didn't have a lot of lows, wasn't having a lot of hypos, wasn't having a lot of highs, I wouldn't necessarily recommend adding another medication. I'm kind of the theory, some people have, some patients also have strange things they do with the way that they take their insulin at certain times of day, and I'm a big believer in not rocking the boat when things are going well. If you have a system that works for you, I'm not going to mess around with it. And so, I don't necessarily suggest it for my patients, but if my patients are asking for it, I certainly will let them try it. In the green shirt.
Would Similant be something you might advise for a young woman who's using diabetic to manage her weight as an alternative to that?
Yeah. So the question is Similant something you advise for a young woman who's using diabulimia to adjust for that? So what I would say is I don't treat adolescents, first of all, but I do have patients, older adults with eating disorders, and who also kind of change the amount of insulin they're taking to adjust for their weight. And I would say that in patients who are afraid to take too much insulin because of the weight gain, or they like running their blood sugars high to help with weight loss, these medications are certainly good options to kind of add on to that. Similant causes weight loss. These other two medications that we talk about also cause weight loss. Yes?
Does the weight loss level off?
So the weight loss does level off, but it is sustained. So it doesn't, you don't lose weight and then kind of regain it. You lose a few pounds. And we're not talking about 50 pounds of weight loss here, but well, in your case, you lost a lot of weight actually on the Similant.
And I've been on it since it first came out.
Yeah. But most people don't lose, most people lose 5-10 pounds or so. But it is sustained, so that, they do keep it off for the most part. And for some people, it's just a nice jump start for weight loss. Yes?
Does that weight come back up if for some reason you need to get off that medication?
Yeah, usually the weight does come back up if you have to stop the medication. I do want to wrap up because we have run out of time here, but I will say please enjoy one of the other choices in the next hour, and I'll be up here if people still have questions. Thank you.
Thank you.